let me see if I could synthesize this, because I'm still confused, actually, to tell you the truth, of where we've ended up here. I agree it's a moving target. I think there's some important issues that we have to deal with. One of them was the mention of, well, if I know the patient had a normal karyotype, then I might do additional testing. It brings up the point that some pathology labs are doing reflexive testing. So I'm going to ask you point blank right now, based on what we're going to talk about later, should FLT3 testing be done as soon as the patient is diagnosed, or wait for a normal karyotype to be shown? What's the answer?
I do it on everyone.
Right up front?
Right up front.
Is there a reason for that?
Yes, because, well, if they're going to get induction chemotherapy,
yes,
I'm going to want to add a FLT3 inhibitor to their frontline therapy.
Or even if they're not getting induction chemotherapy.
And if they're not getting induction therapy,
right?
I want to know, because I might use that in their frontline or in their relapse therapy. I want to know that as quickly as I can. And the benefit is, because the mutation's present, it gives us a target to go after. Even on the RATIFY study, which is a randomized study, a significant number of the patients that were in the midostaurin assigned arm did not have a normal karyotype, and we know there's a benefit.
So again, I want to bring this back to very concrete recommendations for people practicing today. I agree with what you just said. We need to get that information about FLT3, tyrosine kinase domain mutations in internal tandem duplications, because we now have a drug approved for that population of patients, and you have to start it quickly, and you may not, if you don't test, you won't get that information. And if you do next-gen sequencing, you may get it as part of a panel, but it might be too late, because those panels take too long.
I mean, you have to remember that when we are starting a patient on therapy, we do have 7 days of 7 and 3, but we're supposed to be starting the midostaurin on day 8.
Right.
So if you don't send the sample on day 1 or day 2, you may not get it back by the time to start the midostaurin on day 8. So there is an urgency. So yes, I agree. You should do FLT3 in everybody up front. And that, I think, is going to sort of change the immediate treatment of that patient. Some of these other mutations, I would argue, they're going to change the longer term outcome, or the prognostic outcome, or predict for resistance. But the immediate, I mean, what do you think, Jorge? Is that what you do?
Absolutely, yeah. That we also do it on everybody. I think it has practical implications. And I mean, we obviously have to acknowledge that, sure, if the patient has other karyotypes, complex karyotypes, it's going to be much less frequently mutated.
But I think some of the other, like some of these other, until we get these agents, they could wait a week or two to get the molecular data.
Yeah, although, of course, many of these, and in terms of some other practical elements, for at least for our lab, it's less costly to do a panel than individual mutations. So we send a panel for that.
But for people that don't have that luxury,
absolutely, then you would have to send the critical one.
So, and again, the other issue is for the other mutations. Nucleophosmin, CBP alpha, clearly important in normal karyotype AMLs as being prognostically important. We agree that those should be tested.
Absolutely.
ASH and CAP guidelines also strongly recommend many of the others that you have mentioned, P53, IDH1 and 2. But I'm gonna make a statement and tell me if this is correct or not. Other than prognostic information that you get from those, is there any, at this point, clear evidence that one treatment algorithm is better than another?
I think we have those data in older patients with secondary AML, because we have a randomized study saying that patients who got Vyxeos had a better survival than those who got plain 7 and 3. Vyxeos here is the liposomal encapsulation of both daunorubicin and IRC in one molecule. So in that setting, we have evidence that one induction strategy is better than another. And to define who benefits from that, we either need to know a history of prior MDS, prior chemotherapy, or genetic features that would define that.
But there's no molecular features that define
that was cytogenetically defined.
P53 mutations.
So I would argue that molecular doesn't make a difference in terms of selecting liposomal 7 and 3.
Well, but you could look at a P53 mutation and say that in and of itself,
that's not
though
the
it wasn't
criteria.
a defining
that was
criteria
not
for
a
the study.
defining criteria, right?
And although I agree with you, I do wait for some of this information, especially in older patients who I'm getting more and more concerned about giving intensive therapy. If you find a P53 mutation, it leads me towards thinking about a 10-day regimen of decitabine, as was published by WashU.
But I have to
Do
say,
I know that? Do you know that that's better than intensive chemotherapy?
I don't, but I also argue that in a lot of my patients that are older, and you can disagree with me, I'm not in a big rush. Some of those older patients, you know, a younger person comes in, their white count's 400,000, they're hyperleukocytosis, I'm gonna start 7 and 3. Somebody that's maybe not a candidate for 7 and 3, I maybe have a little bit extra time to wait for some of those results before jumping in, right? What do you think,
And that is
Jorge?
true, but you know, the problem here, and you know, going back to the point that Sasha was trying to make here, is this subset of patients with secondary AML that's defined by cytogenetic abnormalities that are associated with MDS. Sometimes the cytogenetic results can take 3-4 weeks.
Yeah.
Right.
And I'm in agreement with waiting, but 3-4
Not
weeks.
3-4 weeks, right.
You know,
No,
and that's
no,
a
no.
problem. If that's going to define your treatment, and if it takes that long, then it starts to become impractical.